Is yeah.
We are live now.
Yeah. So, Shraddha, you go ahead.
Hello everybody and welcome to today's webinar. My name is Shraddha and I would be co-hosting this webinar with my colleague Amrita Vadnerkar. I would like to encourage all our viewers to share today's webinar on our with the help of our social media networks. And so without any further ado, let me please welcome Dr. Stephen from UNICEF for opening remarks. Dr. Stephen, over to you.
Thank you, Shraddha. Good day around the world, whatever time zone you are in. I'm Stefan Peterson. I'm Chief of the Health Section at UNICEF, and it's my great honor to actually open this seminar today. It's one in a series of seminars in a collaboration between the International Pediatric Association, the World Health Organization, and UNICEF. Today will be in English. We also have regular seminars in French and Spanish, and we are considering occasional catch-up seminars in other languages as well. You can watch this if you've been invited on Zoom. Many of you are watching on YouTube, and I would encourage all of you to subscribe to the IPA's YouTube channel. I do, and that means you can also watch this at your own leisure. Today, the topic is around the spectrum of COVID disease in children, what we know at this stage. And as we know, this is an evolving field. But I just wanted to give a framing in the sense that I am actually observing COVID from my native Sweden. And Sweden in many ways is a natural experiment. We have more than 1 million kids going to kindergarten and primary school as usual, sharing their coughs and sneezes with each other. I checked the official statistics of Sweden today. We've had registered no school outbreaks during 2 months of community transmission with all these kids going to school as usual. We have 200 or so registered COVID cases in the first decade and 400 in the second decade of children. And as of 2 weeks ago, we had 4 cases registered of multi-inflammatory system disease. So please keep these denominator issues in mind as we go through the seminar today. We will hear from many distinguished panelists who will introduce each other. I encourage you to, meanwhile, type any question you may have into the YouTube channel, into the chat box, and my co-moderator, whom I'll introduce in a minute, will then take over and lead the Q&A after we have heard from all the presenters. So it's now my honor to introduce Dr. Margaret Fisher, who is affectionately known as Meg. She actually co-leads the IPA's COVID response group. She's chair of the scientific committee for the next World Conference of the IPA, where I presume there will be sessions on the very topics we're discussing today. Meg, she is an experienced infectious disease pediatrician. She's a professor of pediatrics, etc. So Meg, I probably missed half of your credentials now.
Oh, that was perfect. And I'm delighted to be here and happy to be part of this. And I think without further ado, we should go to the lecturers.
Yes, we shall. And the first presenter is none other than the immediate past president of the International Pediatric Association. He's the Robert Harding Chair in Global Child Health at the Hospital for Sick Children in Canada. He is the founding director of Center for Excellence in Women and Child Health at the Aga Khan University. He is a graduate of my university in Sweden. I'm talking about Professor Zulfi Karbuta. Please, Zulfi.
Thank you, Meg. Thank you, Stefan. And I know our time is short, so without further ado, I'm going to try and share my screen, if I can. So let me know if you can see my slides and if you can see them in a full screen view.
Yes, we can.
All right, so ladies and gentlemen, firstly, thank you very much for joining this webinar. My task is to set the scene and to give you a broad overview of COVID-19 and why what we know about COVID-19 today should make it an absolute priority for every pediatrician, irrespective of which geography you work in, to know something about this and to know certainly something about mitigation strategies. So this is from last night. And who would have predicted this in January, that we would have almost 6 million cases of COVID-19 worldwide and over 360,000 deaths. And I'm sure these figures have changed since I made the slide late last night. And you can see from this geography that the hotspots no longer are restricted to a few countries, but it's affected almost every country of the world. And the few who claim not to have COVID have likely not looked for it. What I hope to do over the next 15, 20 minutes is I'll try and cover some of the experience with pediatric COVID-19 infections to date, highlighting some of the important issues for practitioners, the age distribution issue, which I think is very important for pediatricians to know. I'll talk about the direct effects, and my colleagues will talk in detail about the multi-inflammatory syndrome. I'll also talk about indirect effects, which many people are not yet fully attuned to as to what COVID-19 has done to child health globally. I will specifically touch around perinatal transmission and breastfeeding because many pediatricians repeatedly ask this question around what to do about mothers and babies. And finally, I will end with the guidance that in collaboration with many others that the International Pediatric Association has issued recently and that we are trying to update over the next few weeks. So from the first case reports in China, when it came out, it was quite apparent that this disease appeared to spare children to a large extent. Not that children did not get it, but if you look at this data from almost 45,000 cases in mainland China, there are relatively few in children in the adolescent age group and those under 10 years of age. Of the data that we knew, the attack rates from a few areas were around 7% and broadly under 14 in one large case series of 1,000 cases, the attack rate was considered less than 1%. And in this large study, only 125 out of 2,000 cases developed anything like a serious illness. So the data from China early on were suggestive of this being a relatively mild disease. Then we go to the next epicenter of the outbreak in Europe, in Italy. And if you look at this compilation of data from Italy, we have around 1% of its cases in Northern Lombardy in the adolescent pediatric age group. But importantly, virtually no serious adverse effects, either mortality or very serious morbidity at that time reported in this age group per se. In the United States, there have been a number of data compilations and a large report released by the CDC. And you look at overall, it also appears to be the same, that we're around 1.7% cases under 18. Median age appears to be a bit high. So it is not a disorder that affects young infants or children. And I will talk a little bit about underlying condition shortly. What about low and middle income countries? We are also now beginning to see data emerge. This is data from my home country of Pakistan, where if you look at the prevalence of cases by age and gender, you see something similar to what we are seeing in other places, quite a significant preponderance of males amongst the affectees and a large clustering amongst the adult population. And depending upon what population pyramid you have, a relatively fewer in terms of population percentages in older age groups. But you will notice that we have around about 7% in adolescents in terms of case distributions. When you look at mortality, large proportion of the mortality is clustered amongst the elderly. We all know that. But in many low and middle income countries, and now data from Pakistan, Brazil, and Mexico indicates this, that between 25 to 30%, and in this particular instance from Pakistan, about a third of all deaths are in people below 60 years of age, and below 50, it's around a quarter. Important for you to note is that the proportion of deaths in adolescents, there are virtually no under 10 years of age, is relatively small. It appears to be a milder disease. In one comparison of children versus adults, you can see for a range of symptoms in comparison to adults, we have a less proportionate representation of those features in children, even things like shortness of breath and documented hypoxia appears to be much more common in adults than in children. Overall, the vast majority, over 90%, of these children appear to have acquired this from some person in the house or community. And those who are relatively young, and it may be just a feature of pediatricians and family members being very concerned, do end up by being hospitalized. About 60% of those who are in infancy end up in hospital. This proportion is now becoming a little less as people are becoming more aware of the disorder in infants. But yes, the younger you are, and particularly in the newborn period, I mean, there are some concerns that you may be dealing with more severe disease if it does occur. Recently, my group has compiled almost all the available evidence, and this is a moving target. So this is all the evidence from the reported pediatric cases, case series, smaller case series, and larger individual case reports, and altogether about 4,000 children in this particular database. A large proportion of these reports are from China, not surprisingly, but there are several from other countries, including Italy. So if you look at this, a few points to take home. The median age does appear to be greater than 5. So this is not a disorder of under 5 children in general, but it's a disorder that disproportionately affects older children. And if you look at overall as to what proportion of children in these reports are in the adolescent age group, about half of them are. So pediatricians need to be aware of this age distribution. Interestingly, overall, we do see a slight male preponderance, even though a lot of this data comes from geographies where you should not have any differentials by gender in terms of care. And that does suggest some biological predisposition to perhaps more severe disease amongst males, and we can speculate as to that in our Q&A session. When you come to features in this large database, a few things stand out. Firstly, close to around 15% overall are asymptomatic. So these are children who may have been tested just because they are family members or have been exposed, and these are totally asymptomatic children. About 40 to 50%, about half have a fever, and a little less than that have cough at presentation. Dyspnea, tachypnea is relatively rare, but notably about 10-12% have GI symptoms at presentation. So they could present with diarrhea, much more so than vomiting. And I particularly look for hypoxia at presentation, and in all these series, this is a relatively rare occurrence, by and large, overall in the data that have been published. In these 4,000 cases that have been reported across these 40+ studies, overall case fatality rates are less than 0.5%. So only 8 deaths out of 4,000 so in the literature base. So it does not appear to be, at least insofar as the data from this particular compilation is concerned, a very serious disease with a high risk of mortality. It may well change as we know more about the syndrome that many of my colleagues will talk about. So, as I mentioned, if you're very young and in young infancy, you may have more severe disease, but it's a relative statement. And of the proportion of children who do end up in hospital, a very small proportion end up in ICU, about 8%. In China, the proportion of severe and critical cases in young infants was higher than that in older children. And that, I think, is corroborated also by evidence from elsewhere. Pre-existing morbidities. This is an extremely important issue. And in one report of 48 cases from 46 pediatric intensive care units, around 83% had pre-existing comorbidities. I've recently looked at the data from New York, and of the 11 deaths that have been reported out of New York in the pediatric age group, 9 had documented pre-existing morbidities, more often than not a non-communicable disease of the kind that you see in adults. So in summary, yes, maybe a milder disease compared to adults. Overall, about 1 to 2% of cases are in children, and pediatric clinical manifestation appear to be, in comparison to adult COVID infections, rather atypical, with fever and cough being a dominant feature. As I've indicated, the male preponderance is something that we have noticed, but we don't really know much about. My colleagues are going to talk about multisystem inflammatory disease. I'm only going to introduce the topic by saying to you, this is a moving target. And as we speak, of the 200 or so cases that have been recorded in the United States, about 145 are clustered in New York. So that does mean that there is some geographic clustering, and there may very well be features and risk factors associated with this that we are not very clear. I looked for, and I asked colleagues in Iran if any cases had been reported out there. And I can tell you to date, there hasn't been a single report in Pakistan out of the 60,000 COVID cases that have been documented. There are several questions that pediatricians are interested in, and because COVID infection is quite well known in pregnancy, and there is now accumulative evidence that I'll share with you, there are questions around perinatal transmission. Should mothers be breastfeeding? Should they be cohorting with their babies? Should babies be separated from the mothers at birth? How should these babies be handled at the time of birth in terms of handling and resuscitation? All of these questions pop up in almost every webinar that we have pediatricians attending. So intrapartum transmission, theoretically possible. Yes, it can occur through the birth canal, and fetal exposure can be possible. So first question to know is, do you find the virus in vaginal fluids? And there have been a few case reports where people have been able to document this in amniotic fluid, also as well as in placenta. But in the published studies where we have looked at this, in one study of postmenopausal women where they looked at this through RT-PCR in vaginal secretions, all samples were negative for the virus. And a systematic review recently published of 266 pregnant women, which is not the entire universe, only had 6 cases that had RNA PCR positivity in the vaginal mucus, but the newborns were negative for SARS-CoV-2. So there isn't really clear documentation of this being a major risk factor for mother-to-child transmission. And most of the evidence so far suggests that they are acquired horizontally or after birth. This is a recent compilation, again, from my team by Zora Lassi, of looking at 400 plus reports of pregnancy with COVID positivity from 46 papers. And the important thing that I wanted to document over here is that the vast majority of this data comes from China, again, and USA. So we need more geographic information on this. Generally, many of these women have had severe disease. So this is not a very mild problem, but by and large, case fatality rate in this age group or deaths amongst mothers are very rare. On the newborn, I am watching this space quite closely because we do seem to have a prevalence in this population of low birth weight and prematurity, which is a bit higher than what you would expect in this population. And certainly stillbirth rates amongst all births so far appear to be very low. As I mentioned, the COVID positivity in 289 newborns that were tested for this, and some were not reported, generally has been relatively low. So a question being asked by pediatricians is, should we be taking precautions, especially if the status is unknown? And the answer to that is absolutely. You should be taking precautions because of the risk of transmission to the care providers. Whether you need to do it this extreme with perspex covers, etc., is debatable, but certainly using personal protection equipment and gloving and gowning properly is a requirement. We've been asked also what to do with many of these mothers and babies, especially if the results are awaited. And in all instances, prudence is the better response. And as you can see from this one algorithm, and there are several of these now, if the mother's test is negative, you don't need to worry. If the neonatal test is negative, you just need to observe and discharge if samples are negative, particularly if they're negative consecutively. And if the newborn is positive, then you need to be watching that newborn very carefully until there is documented COVID negativity. The diagnosis in newborns is based on certain criteria of COVID infection. And that is at least one clinical feature, some radiological abnormalities which have been documented in a handful of newborns who have presented with this, at least a positive diagnosis in the patient's family or caregivers, and a history of close contact. What about breast milk transmission? There's a big question that's asked, and this has now been extensively looked at. And I know that CDC has a position which is a bit more conservative, but by and large, both in the systematic review, as well as in studies that have looked for viral transmission in breast milk, we have not been able to find any evidence of viral transmission in breast milk. And actually, there is one very interesting study which is available for public view on Medrix, not yet published, which looks at IgA antibodies in breast milk for COVID-19, which does suggest that perhaps breast milk may be providing some protection to babies. And that's one of the main reasons why in the WHO guidelines and UNICEF guidelines and the IPA supports this at this point in time, that we are recommending that in low and middle income countries, mothers should take precautions of hand washing, touching, face mask, but they should continue to breastfeed, and these babies should be cohorted and kept with their mothers and not separated out and taken elsewhere. I do want to spend a few minutes on the indirect effects of COVID on children, which people don't talk about very much. And I think it's now time, 3-4 months into this pandemic, that we should absolutely underscore this. Children may not be the face of this pandemic, but they risk being amongst its biggest victims. And while they've been largely spared the direct effects of COVID, the crisis has a profound effect on their well-being. All children, all ages, in all countries are being affected by this global pandemic, and especially by the mitigation measures. And I'll explain that in a minute. And it's also important to underscore that the harmful effects of this pandemic, the indirect effects that we're seeing on children and families, are not equitably distributed. They are disproportionate amongst the poorest of the poor, and especially in those who are most disadvantaged and vulnerable. What do I mean by this? If you look at lockdown measures, several countries exposed. This slide is a bit out of date now. Several countries have imposed very strict copycat lockdown processes, whereby you just stopped everybody from moving. You close schools. When you look at school closure, that's actually even more remarkable. We, in one stroke, by closing schools, put 1.5 billion children and youth out of the education system. And although there have been attempts to provide internet-based or web-based, and in some instances, television-based education, you have to recognize that many of the poor do not have access to it. They neither have access to the technology, nor are they able to afford the internet bandwidth required for some of those educational strategies that require video streaming. Neff Walker and colleagues from Johns Hopkins recently estimated the indirect effects of COVID on maternal and child mortality in low and middle income countries, and do this using a life-safe tool model. So what they did was to see what could happen if services to children are interrupted. And services, as you know, ladies and gentlemen, are interrupted because outpatient clinics, ambulatory clinics in many hospitals have been closed. Vaccination services have been interrupted in many places. And therefore, it's not surprising that both with the apprehension that families have in terms of taking their children to care providers, as well as services not being available in outreach, including community settings, that many of the coverage rates for interventions have gone down. So what Neff and colleagues looked at was the whole health system impact on coverage of interventions through both demand side, as well as access and provision of services, as well as utilization of services. And they looked at a range of scenarios ranging from very mild to modest effect, 15% reduction overall in coverage of interventions, to at times more than 50% coverage of impact because of these impact on health services. And their figures are shocking. So in these 118 countries that they modeled, if you look at maternal mortality and you look at child mortality, in all of these three scenarios, the impact is massive. And I want you to look at the mildest scenario, their impact of being around 10 to 15%. And they're saying that this could lead to about a 10% increase in under 5 child deaths and about an 8% increase in maternal deaths per month. And in numeric terms, the prediction is that the least severe scenario could lead to around 250,000 additional child deaths and about 12,000 additional maternal deaths. I'm not saying that these are entirely accurate. This is a projected model, but we should all be, as pediatricians, aware of this, just like the models that were there for COVID-19, that we have to do something to make sure that this nightmare does not come true. So these summary consequences of COVID-19 on poverty are massive. We estimate close to 90 million children could fall into extreme poverty, mainly in Africa and parts of South Asia, as a result of this crisis, adding 15% to the already existing 670 million children who were in extreme poverty in 2019. The learning crisis I've already alluded to, and I've mentioned as to how the share of this distance learning platform in many low-income settings is only 30%. And therefore, we really run the risk of exacerbating existing inequities and disparities in education for many of our most vulnerable children, and particularly for the very young, the preschoolers, the kindergarten kids who cannot learn on the web. For them, person-to-person exposure, and particularly with a teacher in those special classes, is extremely important. There are clear threats to child survival and health, and I've talked about those, so I will not belabor that too much, except to say that we believe that close to 80 million children today are at risk because of the adverse effects due to missed immunization. So every pediatrician should be aware of this risk. We also believe that malnutrition is something that might worsen over time, not just wasting as modeled by Walker and colleagues, but also the impact on maternal nutrition, small for gestational age births, and possibly increases in stunting over time, because many of these things cannot be reverted back to normal in a very short period of time. And importantly, you have to recognize that when you lock up people and families in very small quarters for extended periods of time, we significantly increase the risk of child abuse and child violence, and particularly for girls. And this is particularly also notable in those people living in refugee settings and those in conflict zones. So this is something that we are all well aware of. And we are also well aware of some of the mental health consequences of what these mitigation strategies are. I want to finish by saying what can be done, because I don't want to leave you with a doom and gloom scenario. There's a lot that can be done. And certainly the IPA has, in partnership with many others, and this spirit of partnership continues with WHO and UNICEF with these series of webinars, we have put out some statements that we will be updating as more evidence and data becomes available. So we are encouraging in the acute stage of whatever recommendations for staying at home or physical distancing are in place, that people follow what the local guidance is. We are very strongly recommending the use of hand washing and particularly use of sanitizers, as well as face masks when you go out. Now, it's difficult to have face masks in young children, but you need to make sure that certainly children who are about 5 years of age and can comfortably wear a face mask, wear it when they're going out. Community mitigation strategies such as school closures are a problem, and therefore in a number of places, a case is being made for getting children back to some form of safe schooling, and also ensuring that transmission within families can be mitigated by particularly protecting the elderly. We believe that interventions need to be scaled up again, those that have gone down, particularly postnatal care for newborns, particularly breastfeeding and infant and young child feeding strategies, and also care seeking for diarrhea and pneumonia. These access to services need to be also combined with interventions that need to mitigate things that are only just emerging, and particularly the mental health issues are being highlighted in many areas, with strategies that need to include innovations and outreach so that you can provide those services within communities. Routine vaccinations absolutely should not be discontinued. And I know that there has been a break, but we need to get back to speed through whatever strategies are available. And I know we cannot have campaigns, but we can certainly deploy outreach workers and have these vaccines scale up in the countries that are needed. I'm not going to talk much more about case management of children. Most cases are mild and they can be managed at home. But I think putting these measures in place together as a global community of 1 million+ pediatricians and family care providers ought to be able to let us beat this COVID-19 pandemic and build better again. Thank you. Happy to take questions at whatever time.
Yeah. Can you introduce Dr. Rajiv now, Dr. Zulfi?
Okay, right. Wonderful. Let me introduce my dear colleague, Dr. Rajiv Bell from the World Health Organization. And Rajiv will tell us about what WHO's response, and particularly the global collaborative effort around the multisystem inflammatory syndrome that I only alluded to in my presentation. Rajiv, over to you.
Thank you very much, Dr. Bhutta. I'm Rajiv Bahl, as you said, work for the World Health Organization and lead research on maternal, newborn, child, and adolescent health. This multisystem inflammatory syndrome essentially is about a month-old phenomena that we started hearing about, but it's so important not only for it's such great interest in the pediatricians around the world, but in parents and by default everybody else in the population. So what do we know and understand will be discussed by two later speakers as well. And so I will only be very brief in talking about how we have responded to this and how we are trying to understand it better. So as you all might know, an alert was issued by NHS England about these cases of multisystem inflammatory syndrome in children. Some of those who had tested positive, some were negative for SARS-CoV-2. And this became immediately big news everywhere. Information about similar cases was shared with WHO in our clinical management networks and from other European countries, and eventually then immediately, almost immediately thereafter, from the United States. Within a few days of knowing that this was happening in multiple countries, the WHO set up a working group of experts to follow the evolving situation. And there is a group of us who coordinate this, and I lead that with Janet Diaz from World Health and the emergencies part of WHO. The working group developed a preliminary case definition and a case report form. This was part of a scientific brief that was issued by WHO on the 15th of this month, and the CRF was also developed, which has been put on the WHO COVID-19 clinical data platform. And essentially, this is a form that we are asking everybody in the world, all the pediatricians, etc., who see such cases to report these cases so that we can follow the situation and understand this syndrome better. Okay, so the preliminary case definition, and I probably will not go into every single detail of this, but just to tell you how the group reached this, because there are lots of questions some people have around this and why certain things are included or not included. Why is it only clinical, not only clinical based, etc. So essentially what it means is any child or adolescent who has fever of somewhat long duration, mostly people have seen 4 days or more, but here the group said for us to keep a high index of suspicion, keep it around 3 or more days of fever and evidence of multi-system involvement. So either you can see those 5 bullet points there, either something as severe as hypotension or shock, or the skin or mucosa involved, or the myocardial involvement or pericardial involvement somehow, somewhat, which is fairly common in these cases. Any evidence of coagulopathy, or again, another common presentation being acute gastrointestinal problems. So at least 2 of these. So just to make sure that we are talking about a multi-system involvement, at least 2 of these systems involved, evidence of fever with that, plus some evidence of inflammation, laboratory evidence of inflammation, and the group basically kept it very wide, any marker, ESR, CRP, procalcitonin, and then there is a long list after that. If you see, for example, the CDC case definition, etc. So we tried to keep it relatively simple and as one marker of inflammation, and no obvious cause of this kind of inflammation or syndrome, because also we wanted to avoid many of these false positives in the definition that may occur because of bacterial infections or other things that would very easily explain such a syndrome. So this is something that is not explained by an obvious infection. And this last part again has been a lot of questions on this, and I'll talk to you a little bit about what is the plans for the future. Some evidence of either being COVID, of having COVID, which means a RT-PCR positive or serology positive, or maybe some likely contact with patients with COVID. Now, again, this might become irrelevant, but there was issues about that this is from settings with relatively high chance of getting in contact with COVID. As Dr. Bhuttas was showing in his slides, this is changing by the day, and almost every country we are going to at one point have large numbers involved. So this is a preliminary case definition. That is what is very important. It was done to make sure that we have something to start with, look at the data over the subsequent 2 to 3 weeks, 4 weeks, and then come back and review this case definition. Also, as I said, side by side, this clinical data platform is now live. The case report form is available at this web link. And the slide also tells you how to become a contributor and how to actually send any information. It is notable that none of this data that the WHO receives is for publication or in peer-reviewed journals or elsewhere. This is for a public health response solely. So the contributors retain control of their data for publication, etc. And the contacts are shown. The update on this situation since May 15, we expanded the working group for increasing geographical and other representation. And in addition to global experts and WHO and UNICEF Secretariat, US CDC was already included earlier, but it's still there. And the European CDC has also been invited to be part of this group. The expanded working group met earlier this week, and a quick update on that is, and that was discussed, is that there were more than 600 cases globally, and when the people who were present talked about, of course, as Dr. Bhutta was saying, UK, USA, France, Spain, Switzerland, Canada, Brazil, Ecuador, Mexico, and even some 3 suspected cases from Pakistan, from the person from AKU. It's slightly different from what you just said, Dr. Bhutta, but this was the pediatric emergencies person who was part of this group. And this is to be fair, we cannot say that these are all confirmed cases at this stage. Another finding is that the cases in UK and Europe are now kind of decreasing. Some people are not seeing many cases anymore. And there have been at least 5 deaths. Dr. Bhutta said 6. So maybe the group at that moment didn't know about 1. Clinical features are still quite similar, but one is some people are seeing a less severe version of the disease. And this can have 2 possibilities. A, that we are probably doing earlier identification or identifying those that were being missed before, or that because of the vigilance and treatment, and if treatment is effective, all that is hypothetical at this moment, that we are seeing less severe cases. People are using various modalities of treatment in which IVIG is most commonly used. Steroids and other immunomodulatory agents have been used, and even reports of some children who have recovered without any specific treatment. So I would let this to be detailed out by Karen Wilson, Professor Wilson, and Professor Mike Levin, who will speak after me. But I'll just tell you what the next steps as far as we are concerned are. that the working group will review the case definition in about now, not in 2 weeks, in 1.5 weeks from now. And we request all pediatricians globally to remain vigilant and to report cases to the WHO clinical data platform, including those people who are working in low and middle income countries, which may not be seeing any cases yet, but just to remain vigilant. And then there is also a lot of discussion that is ongoing in the research network that we have on response to what research response is required, for example, to different treatment needs, etc. And Professor Levin will also talk more about that, basing it on either clinical outcomes, which is slightly more difficult in terms of, because we don't have many poor outcomes as such, or on change in inflammatory markers, and he will speak more about that. So that's all from my side. Thank you very much for listening, and look forward to the other 2 presentations. Now, unfortunately, I did not get this, that I have to introduce the next speaker. So
I will do it for you. I will do it.
So
thanks, Dr. Rajiv. And now we move to Dr. Karen Wilson. She is the Professor and Chief of Division of Pediatrics at Mount Sinai Hospital, New York. And she has been at the forefront of managing these pediatric patients, including the multisystem inflammatory disorder in New York, which perhaps has now the largest cohort of such children. So over to you, Professor Karen Wilson.
Thank you so much for that, Dr. Gupta, for that introduction. And thank you for having me today. Thanks to the IPA, WHO. I'm delighted to be able to talk to you about the experience that we've had in New York City and talk a little bit about our clinical management of these patients. So my objectives are to review the experience of just one New York City hospital. And I want to make it very clear that this is our experience and this may not be the experience of even other hospitals in New York City. We do have a very large network. So we're an 8-hospital network. And so we get a lot of patients in the pediatric realm from that. But we had a huge adult population. We had up to 650 patients admitted with COVID at our main hospital, Mount Sinai Hospital, at any one time. So much of our efforts were focused on the adult side. I'll also talk a little bit about both our pediatric COVID-19 and also our multi-inflammatory system in children patients that we've seen, and then share our approach to these patients. As I said, it's just one institution, and we've been making up the guidelines as we go along, as everybody has, because this is so new. So I think, as everybody has seen, our initial impact really suggested that this was not going to be a serious illness in children. We had a very low number of patients who were admitted with COVID-19, a total of about 40. I think our total number of adult patients that were admitted was well over 5,000. So much lower prevalence of admissions for pediatrics. In fact, we actually sent some of our providers to the adult hospital to provide care. So we had pediatricians as attending physicians on COVID wards in the hospital. And we agreed to take older patients on our pediatric floors because they were so strapped on the other side and we had space. What we did see with those cases early on, as I think was described before a bit, is that few of them were very seriously ill. We did have a few that got quite sick, only 1 or 2, and those, as mentioned earlier, had other comorbidities, particularly oncologic cancers under treatment. We also—
Karen, your slides are not moving. Can you, can you make it a slide sorter, a slide so move?
Can you see? Am I on the one that's labeled NYC Children and COVID-19?
Yes, can you make it into a slideshow as well?
Let's see, sorry about that. Let's see.
Dr. Karen, do you want us to share your slides?
Sure. Let me just, I must be sharing the wrong one. How about this? Is that better?
No, we can't see the slide. We can only see you.
There?
Yeah.
Yes.
Okay. Sorry about that.
Perfect.
Okay. Okay, great. Is it moving?
Yes.
We did see an interesting cluster of patients that were admitted later on. So these were kids that had been exposed to COVID a little earlier, but were immunocompromised. And they were generally admitted for fever as a rule out sepsis. So these were kids where we were concerned that they might have bacterial sepsis. They were admitted and they were found to be COVID positive and were never critically ill. And we did have at least one patient with Bruton's gamma globulinemia who did have pneumonia and was treated as a COVID positive respiratory illness patient. We did have some patients admitted for other reasons who tested positive, just incidentally. So in particular, appendicitis did not stop for COVID. And when those kids came in, a couple of them did end up having a positive COVID PCR. And then we also had a patient who was admitted with a neonatal fever. And I know we talked about how the admissions tended to cluster in that age group. And I think probably many of those were in this situation. So they had a fever, they were admitted for a rule out sepsis protocol, and they were determined to have COVID-19 on PCR. And this, at least in our patient, was a very mild illness. So now I want to pivot a little bit and talk about our experience with pediatric inflammatory multisystem disease, or multisystem inflammatory disease in children, as it's now become known. We have now seen about 22 of these kids. And as we talked about with the case definition, there is a little bit of wiggle room in that. And so I think I know that our definition in New York City is actually a little bit different than the definition that the WHO has. But we think we've had about 22 of these patients. Most of them are admitted to the ICU. We've had a couple that have come to the floor, and then gone to the ICU. But now I think we've had one or two that have actually come to the floor and been able to be treated on the floor without having to go to the ICU. Our age range is about 30 months to 20 years. We do have a patient currently that we're not really sure it's MIS-C, who is 13 months old. That would be pretty young from what we've been seeing. The symptoms, as described earlier, typically fever greater than 3 or 4 days. Greater than 4 days is the case definition in New York State. Abdominal pain, diarrhea, rash, and conjunctivitis are all, either some of the kids seem to have the abdominal pain and diarrhea, the GI symptoms. Some of them have more rash and conjunctivitis, and some of them have both. Most of these kids have had a history of COVID exposure or a positive test about 2 to 3 weeks prior. And most of the ones that we have seen have been PCR negative and antibody positive. I did see there was a question about whether the case definition should include a positive antibody test. And I'm not sure if we can discuss this later, but I know for us, all of our patients have been antibody positive, but we have a very, very sensitive and specific test. And so I don't know whether once all of the testing is highly sensitive and highly specific, whether we can move towards that. And most of these kids have recovered from their initial illness, if they had any. And in fact, most of them reported maybe mild cold symptoms, but typically they did not have any kind of severe illness or even concern for pneumonia or anything like that when they had their initial illness. So this was a new onset of an illness for them. And all of our kids so far that have had MIS-C have been previously healthy. So some of the clinical features that we've seen, it's a very quick progression for these kids from hypotension to hypotension and shock. And so we've been really encouraging our network of outpatient pediatricians to be checking blood pressures in kids that they are concerned about MIS-C. They don't tend to be fluid responsive. And I think the general recommendations are now to only give 1 or 2 boluses, or maybe 2 boluses before you start pressors in kids that have a high index of suspicion for this condition. Some of the things that we found are an increased ferritin, although not as increased, maybe in the hundreds, not in the thousands, like you might see with macrophage activation syndrome or HLH. A very high CRP in the 200s to 300s, elevated D-dimers, elevated troponins, particularly in the children that have some cardiac injury, increased BNPs, as well as increased IL-6. We've had a couple who have also had an increased IL-1, which is sort of interesting, and that has helped us guide our therapies. We are getting cytokine panels now on all of these children, and once again, that has helped us decide which of the medications and therapies we are going to be using. We also are seeing decreased lymphocytes on labs. Many of them have had acute kidney injury and or increased liver function tests. And many of them have had echo abnormalities. They can have either coronary artery involvement or LV dysfunction. A couple have had both, but mostly it's been one or the other, and more heavily weighted towards the left ventricular dysfunction. And the support has run the gamut, everything from room air to intubation to ECMO. And we did unfortunately have one patient who had been on ECMO who did pass away from this. So we are one of those very few deaths that have been reported from this condition. The way that we have been treating this here, and remembering it's one site, we have conferred with our cardiologists, our hematologists, our rheumatologists, and our immunologists and ID doctors to think about how we want to approach this. And the way that we have ended up deciding to manage these patients is most of them are getting IVIG, and then most of them end up getting tocilizumab. We're doing this when they have an elevated IL-6, and most of them have. The few that have had elevated IL-1 have gotten anakinra. Most of our children are getting Lovenox, and we're basing that on their D-dimer. So we're worried about the increased risk of clotting if they have an elevated D-dimer, and then that will guide us towards whether they're getting a prophylactic or a therapeutic dose, along with their echo findings and any sign that they might be hypercoagulable. We have used remdesivir, but only for patients who have a positive PCR, which just indicates that they may have a current active COVID infection. And so we would give it to those patients. And that has been honestly very few of the MIS-C patients, but a few more of the immunocompromised patients. So for instance, the patient I spoke about earlier who had pneumonia with COVID did get remdesivir, actually, as well as convalescent plasma. So the course of the patients with MIS-C, most have slowly improved and been discharged from the hospital, except for the one case that I spoke about earlier. We are giving them close follow-up with their primary care doctors, rheumatology, cardiology, and hematology. And we're delighted that they actually are doing quite well. They have 1 and 3 week follow-up visits. Most of the cardiac anomalies have actually normalized at this point. Most are now off of Lovenox because their D-dimers have gone lower. And but the hematologist is going to keep them on aspirin for a period of time to make sure that they remain not coagulable. A quick word about precautions, because this question came up. So we, for COVID, we do have special droplet and contact both. Special droplet being surgical mask for usual care and an N95 for aerosolizing procedures. We are, and also a face shield. For contact, we're having, we wear a gown and gloves. We have specific donning and doffing procedures that I'm happy to share with you. I think they're on the Mount Sinai website, but it's a protocol for getting the PPE on and off without actually contaminating yourself. Obviously, hand hygiene and cleaning. N95s are not required for all patients, but they are often worn for all patients. And we also have both extended use protocols for N95s, which means that you wear one N95 for the entire day, and limited reuse protocols, which means that you have an N95 mask that you wear for one patient that you take off and then you wear it again the next time you go and see that one patient. We also we only require negative pressure rooms for frequent aerosolizing procedures. And those procedures include BiPAP, CPAP, high flow, intubation, bronchoscopy, and BAL, bronchoalveolar lavage, as well as nebulizers, chest PT, deep suctioning, and tracheostomy. And interestingly, as we started having a COVID, we actually started running out of albuterol nebulizers because they were being used so much, albuterol MDIs, the inhalers, because people were trying to use those more than the nebulizers to avoid the aerosolizing procedures. So you can do that with a patient who has asthma that you might have some concern about COVID. You could actually have them use an MDI rather than a nebulizer and not require the negative pressure room. To remove precautions for the inpatient setting, once the patient has been afebrile for at least 72 hours without antipyretics and a marked improvement in symptoms and negative results of the PCR, from at least 2 consecutive nasopharyngeal specimens collected 24 hours apart. So there's a lot of things that we do to remove the precautions. In the outpatient setting, we would not have to use precautions for an outpatient visit if at least 10 days have passed since the onset of symptoms, or they're asymptomatic. If they're asymptomatic, at least 10 days have passed since the date of the first positive COVID-19 diagnostic test, and the patient has been afebrile for 72 hours, and there's a marked improvement in symptoms. So patients who are discharged before 2 consecutive negative PCR tests are performed are not required to repeat testing if 4 weeks have passed from the onset of symptoms and the patient remains free of symptoms of COVID-19. And for us, we don't require repeat testing for clearance in the outpatient setting unless somebody's coming in for a procedure that we require pre-op testing, pre-procedure testing like surgery or chemotherapy, and those we are doing. So this is where our institution and our infection prevention group has landed for precautions for all patients across the institution with COVID. And we do now, our kids who have MIS-C, if they have a negative PCR and are positive, a positive antibody test, they're actually standard precautions at this point. So I'll close with just a few reflections. So this is very similar to the cases that were reported from the Italy and the UK and around the world at this point. It really is not completely consistent with Kawasaki disease or toxic shock syndrome. It's talked a lot about as something that's very much like Kawasaki, but it's really important to consider this a separate entity and treat based on the patient's data. This is something where we can certainly look at the lab values and treat based on that. So we're treating D-dimer, we're treating IL-6 and that sort of thing. And it seems so far to be working for us relatively well. It appears to follow the infection by 2 to 3 weeks. And as you've seen the slide, you will see the slide about how it lags behind the adult cases. And I think it's important to remember that this is incredibly, incredibly rare. We've only had 176 cases in New York State, and this is out of 360,000 positive tests for COVID in New York State. And I think if somebody asks, are we testing kids? And at least in our system, no. Up until now, we've actually been actively telling parents not to get their kids tested because we didn't want to bring COVID positive kids out into the community and potentially expose other people. So our testing rate among children is really probably quite a bit lower than our testing rate among adults. And so I think that the overall prevalence of this syndrome is very low. And I think it's important to remember that the risk is low and that these kids are actually doing okay now that we've had a chance to follow them up for a little while. So that is all I have, and I will introduce our next speaker. I am delighted to introduce my colleague, Dr. Michael Levin. He is a professor of pediatrics and international child health at Imperial College of London. He's a pediatric infectious disease consultant and an expert researcher focused on diagnosis and treatment of a range of childhood infections, including meningococcal disease, tuberculosis, sepsis, Kawasaki disease, and now multisystem inflammatory disorder in children. Go ahead, Dr. Levin.
Thanks very much. I'll just try and share my screen. Is that shared?
No, not yet.
Is that shared?
Yeah.
It's coming. You speak just a little louder, please.
Right, okay. Well, thanks very much, Karen, for the introduction, and thanks very much for this invitation to participate in this webinar. I think it's been such a learning experience for pediatricians all over the world as we've tried to learn about a new disorder, and it really is a wonderful to be able to hear about the different experiences of people in different parts of the world as we try and put together an understanding of a new disorder. I'm going to talk about work that has been done in London by a whole lot of people. So I'm really speaking about work done by my colleagues at Imperial College and also at Great Ormond Street Children's Hospital and Evelina Children's Hospital. And we've had a lot of support from the NHS in England and a whole variety of groups have contributed. So in March, just as the country was entering lockdown and we were becoming familiar with the situation for children, which had been the pattern in China, seemed to be having very mild disease. And I think in a way, the only good news story in this terrible pandemic has been that children seem to be much less affected and have mild disease compared to adults. And so we were quite surprised when we started having children admitted to children's wards at the end of March and the beginning of April, who had an illness that we just didn't quite recognize. It didn't quite fit into the patterns of other diseases. Only a small proportion of them were PCR positive for COVID. Many of them had non-specific symptoms, but prominent were abdominal pain, vomiting, and diarrhea. Some had rash and conjunctivitis. And what was worrying is that some progressed to shock and organ failure, and particularly with very severe myocardial failure. What they had on their blood tests was a really striking elevation of inflammatory markers. They had very raised C-reactive protein, very raised ferritin levels, high neutrophil counts, very low lymphocyte counts, and evidence of coagulation activation with D-dimers being elevated, yet fibrinogen levels were very high. Some of the patients looked like they might have Kawasaki disease, but they also looked unusual for Kawasaki disease in that they were older and they didn't have the prominent lymph node involvement and mouth and lip involvement. It was more erythematous skin rash and conjunctival injection. So we became alarmed when several communications between a number of hospitals said we were all seeing a similar picture. And in early April, we became sufficiently worried that there was an emerging disorder, that NHS England was notified, and we were asked to put together a case definition so that surveillance for this could be established. So in order to establish a case definition, we systematically reviewed all the suspected cases. A panel of infectious diseases and intensive care specialists looked at all the cases. In particular, we attempted to make sure that all other conditions which might overlap, including bacterial sepsis, staphylococcal and streptococcal shock syndromes, and viral infections associated with myocarditis and macrophage activations, were all excluded. And by the 24th of April, we were convinced that all of the diseases that could produce the same picture were not around, and therefore the NHS in the UK issued an alert. And this just shows the time course of emergence of these cases. And it is interesting to note that they only began to emerge about a month after the curve of the upsurge of COVID-19 in London, suggesting that this wasn't happening at the same time as the pandemic, but was happening approximately 4 to 6 weeks later. The clinical features are very much like Karen has described from New York. The major problem and the major reason for admission to intensive care was shock with myocardial failure. Many of the children had an erythematous rash. A proportion of them had conjunctivitis, with a lower proportion with other mucous membrane involvement. A striking pattern of severe abdominal pain, abdominal distension, diarrhea, and vomiting. And 3 of the children actually underwent laparotomy because the surgical teams were convinced they had an acute abdomen. Only no surgical cause was identified. Many had elevation of creatinine, but none required hemodialysis. And unlike adults with COVID, the respiratory symptom seemed to be minimally affected and really wasn't a major prominence. As we've had more experience and the numbers of patients has increased, it looks as if there are actually 3 groups of patients. First of all, the group, which was probably the group that was first recognized, which is the critically ill children with shock and organ failure. Then there are a group of patients who do meet the definition for Kawasaki disease with 4 out of the 5 mucous membrane and cutaneous features. And then there's a group who don't have shock and don't have features of Kawasaki disease, just have persistent fever, but with very marked inflammatory marker elevation. From the laboratory point of view, the results were very much like Karen described for patients in New York: striking elevation of the CRP, elevation of ferritin and D dimers, high levels of fibrinogen, but very low hemoglobins, marked lymphopenia, and low albumin. And then of great interest for the cardiac decompensation that we were seeing is there were some patients with extremely high levels of troponin and pro-BNP as markers of cardiac injury. So as has been discussed, following the Royal College of Pediatrics and Child Health alert and a definition that was put out in the UK at the end of April, there were definitions of the disease published by the American CDC, and then on the 15th of May by the WHO. And all of these definitions, I think in all cases, we recognize, as Rajiv said, that these are preliminary definitions because we were attempting to learn the full spectrum of the disorder. The CDC and the WHO definitions required that there was some evidence of COVID infection, either antibody or PCR positive or contact. The UK definition did not ask for this, and one of the reasons was that particularly early on in the arrival of the pandemic, antibody testing was not easily available, and there was marked variation between the sensitivity of different antibody tests. And we felt that this requirement would not help clinicians who had to make management decisions based on the clinical picture. However, they would be very important in later epidemiological studies. So I think the picture emerging by early May was that we had COVID-19 itself causing a relatively mild disease in children, except if there were underlying comorbidities and immune deficiency. We had the tip of the iceberg, which in the UK was referred to as pediatric inflammatory multisystem syndrome, temporarily associated with SARS-CoV-2, and which was given the multisystem inflammatory syndrome associated with COVID in the CDC and the WHO definition. And perhaps not covered by all the definitions was that we started to see larger numbers of children who were contacting specialist units from district hospitals because they had persistent fever. They didn't have evidence to suggest Kawasaki. They weren't having the shock presentation, but they had extremely high inflammatory markers and no other cause for it found. On this question of whether there was a need for proof of COVID-19 antibody or PCR, we compared the patients in the UK series that had either evidence of antibody or PCR for COVID-19 or not, and we found their clinical and laboratory features were exactly the same. So what is this new disease? And I think like any new disease, many different people had very rapid thoughts on what it might be, depending on what their orientation was. And this is, I think, from the Indian parable of the blind men feeling the elephant in the dark and all declaring it's a different animal. The Kawasaki world suggested there were overlapping features with Kawasaki disease. The inflammatologists and the rheumatologists thought there were features suggestive of macrophage activation, and the infectious disease raised the worry of this being related to staphylococcal toxic shock syndrome. we've attempted to look at this in a systematic way, and we were very fortunate in having a very long-standing collaboration between our group in Imperial College in London and the group of Professor Jane Burns in San Diego, who's one of the leading authorities on Kawasaki disease. And we contacted Jane and said we were seeing patients with some sort of features of Kawasaki. Would she share her database of over 1,000 patients with Kawasaki disease or Kawasaki shock syndrome so that we could do the comparison? And I think it's really an indication of the huge level of cooperation and trust between pediatricians in different parts of the world that Jane didn't ask if we would co-publish. She didn't ask if we needed a material transfer agreement. She simply said, you'll have the data tomorrow. And the next day we received the complete data of 1,000 patients with Kawasaki disease. And we were therefore able to do this comparative analysis shown on this slide. And so what we have here is in the red bars is the patients with the new inflammatory disease, the pediatric inflammatory multisystem disease. In the blue dots and boxes, we have the Kawasaki disease, 1,000 children. And in yellow, we have Kawasaki shock, because pediatricians are familiar that some patients with Kawasaki disease have a shock-like disorder. And then we had patients with staphylococcal and streptococcal toxic shock syndrome, which we had recruited to a number of EU-funded studies that we've recruited patients from across Europe for over the past few years. And what you can see from the slide, there's a lot of information on the slide, but I'll take you through it. The children with the pediatric inflammatory multisystem disorder were older than the Kawasaki or Kawasaki shock. They had higher white cell counts. They had higher neutrophil counts, the overlapping toxic shock syndrome. They had very marked lymphopenia compared to either Kawasaki or Kawasaki shock. Their hemoglobin levels were lower. Their platelet counts were lower. Their C-reactive proteins were higher than either Kawasaki or Kawasaki shock, the overlapping toxic shock. Their liver enzymes were overlapping. The albumin levels were markedly lower than either Kawasaki or Kawasaki shock. And the ferritin levels were markedly elevated. And in particular, troponin and D-dimer were elevated. Troponin very much more than Kawasaki, the D-dimers overlapping. And I haven't shown on the slide that the BNP levels were markedly elevated in those patients that developed shock. So what are we looking at? This data to us suggests that this is a different disease to either Kawasaki or Kawasaki shock syndrome. And there were also significant differences from staphylococcal toxic shock syndrome. We don't know what the mechanism is, but it has emerged coincident with the arrival of the SARS-CoV-2 pandemic. And the illness we are seeing in children with inflammation seems to be happening 1 to 4 weeks after the infection. So as Karen also noticed in the experience of New York, these were generally children who had a mild illness consistent with COVID a few weeks before they presented. And so what we might be seeing is that the vast majority of the many, many thousands of children who have SARS-CoV infection and have a normal immune response simply have a very mild illness. And then we have this group of disorders, which is seems likely as it's occurring just when acquired immune responses are developing. What we may be seeing is an aberrant immune response, which in a small proportion of children leads to this inflammatory state in the group that just have fever and inflammation. It leads to the children with shock and multi-organ failure, and in some patients results in a Kawasaki-like disorder. And it's also of interest that there are so many similarities between the inflammatory disease we're seeing in these children and the delayed inflammation reported in adults with severe COVID, that we may be seeing the same thing. Is there any evidence from other studies that an aberrant immune response is occurring. Well, in the SARS-CoV-1 literature, there is a worrying body of data to suggest that antibodies, particularly against the spike protein, may actually enhance disease by causing macrophage activation. And this is really a worrying picture that seems very similar to what we are seeing. In the case of Kawasaki disease, well, we say this isn't Kawasaki disease. There may be clues from what we know about Kawasaki disease. And one of the things that the genetics of Kawasaki has taught us is that virtually all the genes that are involved in susceptibility to Kawasaki disease are genes that control either the production of antibodies, class switching, or the clearance of antibodies and immune complexes through the Fc gamma receptor. And it's interesting that one of the first publications that I was ever involved in, and has been repeated in other studies, is that immune complexes are documented in Kawasaki disease, which interact with the Fc gamma receptor to cause inflammation. And that may be something like what we are seeing in these patients. So from the clinical point of view, this emerging spectrum raises a number of very important questions. First of all, what determines why a mildly symptomatic child with COVID at a few weeks later becomes a child with fever and inflammation? And then what is the link between the group with fever and inflammation and the group with Kawasaki-like picture, or the group with shock and multi-organ failure? And a particular concern is what is the risk of coronary artery aneurysms? This is a terrible picture, not of COVID-related illness, but of one of our children with Kawasaki who had a huge aneurysm and a myocardial infarction. What is the risk in all three groups of coronary artery injury? And we don't yet know because the numbers are still small, but there is evidence that some children just with fever and inflammation are getting coronary artery dilatation. Definitely the group who have a Kawasaki-like picture can get coronary artery dilatation, and some of the shock patients do. And what is the risk of progression from the febrile child to the more severe picture? And one clue might be that the earlier cases that were recognized seem to be very much more severe. And one reason they may have been very much more severe is that because of lockdown, there was a reluctance to seek care and they may have presented later. And I think this is an issue that Zulfi raised in the unexpected effects on healthcare delivery. So there does seem to be that if there is a delay in treatment, we may see progression. What about treatment? And what the question that we're all facing is what treatments will prevent the coronary artery injury and what treatments will prevent progression? And are we able to predict which patients are at risk of coronary artery damage from any biological markers? So I think these are really issues that we are going to be grappling with as the research community and the clinical community attempt to understand this disease. What determines progression from the mild febrile inflammation to the severe phenotypes? What is the risk of coronary damage in each group? What is the relationship between this Kawasaki-like disorder associated with SARS-CoV-2 and the disease that we are more familiar with of Kawasaki disease? And then, as Karen mentioned, different groups are treating patients with different immunomodulatory treatments, many using immunoglobulin and steroids and what seems to work for Kawasaki disease. Do we know if any of these work? And really, from the data, I've shown that this disease isn't Kawasaki disease. Are we doing the best treatment by giving them the drugs that work for Kawasaki disease, or should we be using different agents? Of particular interest for this webinar, knowing that many countries do not have access to either immunoglobulin or to the biological agents that have been used, such as anti-TNF, anti-IL-1 or anti-IL-6. So what treatment should be given for this condition in less resourced countries? And that's maybe something for discussion. Clearly, steroids are easily available, but may also have side effects in countries with high prevalence of TB and HIV and other opportunistic infections. And then what are the mechanisms, and are there biomarkers that distinguish the groups? I'll share work that is still in progress, but we've attempted to see, are there blood markers that tell us which children are going to progress to shock? And this would be of great help in managing the patients if those presenting to emergency departments or district hospitals could undergo a blood test that will predict who is at risk and needs more treatment. And I think what this shows, the dark blue is the shock patients, the light blue, the non-shock patients. Those who became shocked had strikingly more elevation of CRP. They had markedly reduced albumins compared to those that didn't become shocked. They had higher levels of ferritin, and particularly they had high levels of the marker of cardiac injury, BNP, and also of troponin levels, and less so of D-dimers, but also of LDH. And so this obviously needs repeating in much larger numbers of patients, but may give a help in deciding which patients need more aggressive treatment.
So Michael, just giving you a heads up on time, so we have time for a few questions.
Right, I've got three more slides and I'll go quickly. So as been mentioned, we don't know what treatments work. They've received a range of treatments. And what we are proposing, obviously what we'd really like is randomized placebo-controlled trials, but the situation has evolved too rapidly and we have many hundreds of patients already treated on clinicians' best guess. And what we're proposing is an international study of the best available treatment, which lets every clinician do what they think is best for their patient, use whichever agents they think is available. But as long as we capture the data, we may be able to work out what is working. And the reason this might work is that we've got very good biomarkers of severity in terms of the inflammatory markers and very good markers of outcome in terms of the cardiac injury, the coronary artery aneurysms, and the progression to shock. And so as long as we can match patients for severity, we ought to be able to use machine learning and other mathematical models to show which treatments, as indicated using CRP here, does no treatment result in a slower resolution than immunoglobulin or steroids. And so this study will be available and open to people from any countries. There will be a website and a contact address. And because it's completely anonymized, the data can be entered onto an internationally database and analyzed. And everyone who submits patients will be part of the study group and have joint ownership and write-up of the data if it's published. This is really a collaborative effort to try and work out how we should treat the patients. So I'll end by saying we also need biology, and we really need to try and enroll these patients into research studies. There is a EU-funded study in Europe called Diamonds, which is already enrolling these patients, and we'll be hoping to study the genetics, the biology, the role of antibodies, and we would encourage all people who are seeing them to try and enroll them in local studies. And I'll conclude by thanking for the opportunity to share this data and be very happy to take questions and share in the discussion. Thank you very much again.
Thank you. And I want to thank all of our speakers. I think we have had very terrific discussions of COVID disease, of this multi-inflammatory syndrome. And I think the call for international collaboration is really what the International Pediatric Association is all about. And the idea that we will have the ability to get this kind of collaboration either with the World Health Organization or in the studies with the UK, I think we're really, this kind of collaboration can only move us forward more quickly. I want to get to some of the questions. There were some questions about management of COVID disease in general, and a question about antiviral properties of some other drugs that we use, such as doxycycline, spiramycin, tigecycline, and then also about immune modulators such as zinc, vitamin D, vitamin C. Sophie, maybe you could comment on the use of any of these agents in treatment of the disease.
Thank you. Thank you, Meg. Zinc was used in earlier cocktails by some French practitioners as part of their mix of therapies. But insofar as I am aware, there is as yet no evidence that either zinc deficiency predisposes to a more severe version of the disease, or that zinc therapy, either in standard doses or in high doses, has any immune modulatory effect in these cases. Vitamin D, on the other hand, is a subject of intense research and speculation right now. There are, as far as I'm aware, at least 3 trials of relatively high dose vitamin D supplementation in some of these subjects. I think the major interest for pediatrics would be if there is evidence of preventive vitamin D supplementation in terms of mitigating any of the severity of this disorder. Suffice it to say that it's highly unlikely that any one single micronutrient in this particular circumstance will have any benefit, as has not been seen for cases of pneumonia and other forms of respiratory illnesses. Thank you.
Thank you. I'd like to turn now to Karen. There's a lot of questions about how will a pediatrician be able to differentiate this illness from other febrile illnesses such as malaria or dengue, or, you know, as we think internationally. What is it about the multi-inflammatory syndrome that will help them out? And then I'll ask Dr. Levin to comment as well. But Karen, you start.
Sure. I think it is hard because I haven't treated these kids without having the labs, and so and I don't do the initial evaluation. So I'll just take it with a grain of salt. Some of the things that we've seen with signs and symptoms, first of all, I think the blood pressure is really important, and that can be gotten anywhere. And I think it's really critical to follow that, and don't ignore a blood pressure that seems a little soft, thinking that maybe it's just a misread or you use the wrong size cuff. Really get it again and follow that over time. And I think that's one of the most critical things that you can do. Then I think the other thing is to look at are the signs and symptoms. And so these kids come in looking okay, but not great. If you have a child who has a fever of 3 to 4 days, I wouldn't worry so much about a fever of a day or two, but for 4 days, I would start to worry about this. And then obviously looking at whether they've had a history of exposure to COVID, whether there's been a parent who's had respiratory symptoms, whether they've had respiratory symptoms, things like that might give you a clue that this would be a COVID MIS-C case.
Thank you. Mike?
Thanks. Well, a really important question and an extremely difficult one. And I think the distinction of a relatively rare inflammatory disease from malaria, sepsis, TB, and all the usual things that, including dengue and so on in other countries, is going to be a huge challenge and is really going to need a lot of thought in how to, what sort of algorithm to follow. And I suppose perhaps the first thing is that always the treatable diseases needed to be treated and excluded. So obviously malaria and bacterial sepsis always need to be excluded first. And I think all the children we're seeing in the UK are getting antibiotics because they look like sepsis, because they've got elevated white counts and elevated CRP. So I think that algorithm of first treat the treatable and rule out bacterial sepsis and treat them with broad spectrum antibiotics appropriate for your spectrum of bacteria in whichever country, I think is going to be important, and obviously ruling out malaria. Distinguishing from dengue and other conditions that might also lead to shock and also have fever and a red rash and conjunctivitis, what is striking about these patients is that the blood tests look like bacterial infection. So they've got strikingly high white cell counts, strikingly high C-reactive proteins, And that, I think, should distinguish from most of the other viral infections. But I think it's going to be very difficult in countries that don't have access to laboratory resources and can't measure the range of inflammatory markers that point to this disorder. The presence of a mixture of rash, some conjunctival injection, the persistence of the fever despite antibiotics, I think all of those things would lead to worry about this condition. And then, as Karen has said, the signs of shock developing are going to need to be treated in whatever resource community you are. I suppose the biggest question is, at which point would we use steroids or whatever anti-inflammatory are going to be available in less resourced areas? And I think I really think this is something that's going to be needed to debate it very carefully, weighing up the benefits of treating it. We have the impression from UK and United States and Europe that anti-inflammatories work like immunoglobulin or steroids, but we don't know for certain. And I think we're going to have to very carefully weigh up benefits versus risks of large doses of steroids in countries where there is a higher proportion of TB and other opportunistic infections to worry about. So not an easy question to answer, and one for a lot more thought and discussion and pooling our thoughts.
We are now approaching the 90-minute cutoff for this webinar, I'd like to end up with two questions. For people who have to leave, we understand that you will have to leave. We will continue to answer a few more questions. I think the fact that this multi-inflammatory syndrome is related probably to antibody raises some questions as to what happens when we have a vaccine, or how do we ensure that the vaccine isn't going to make this, isn't going to increase the incidence of inflammatory syndromes. So I wonder if someone might want to comment on that. And then, Sophie, I'm going to give you the last words at the end to talk about public health and what public health interventions can be done to try to slow down the progression of COVID globally. But Michael or Karen, do you want to comment on the vaccine, and should we worry?
I'm happy to have a crack at that question, because it is the one that is really worrying. If this is an antibody or a T-cell mediated event occurring as acquired immunity develops, if a vaccine triggers the same sort of response, a vaccine may make disease worse. And we have examples of that from the dengue vaccines and the early RSV vaccines. I really think this is an issue that is going to need absolutely careful study so that we don't have a setback of the vaccine development because we have some sort of disease enhancement. And I think all the patients that we see with this, we should do every effort to get them into studies that can look at what is the difference between their T cells, their B cells, their antibody responses, particularly because we need to see that we don't have an adverse effect of vaccines.
Karen, did you have other thoughts?
No, I would completely agree on that. It is definitely a concern. And the same concern has been raised for convalescent plasma as well.
Yes, good point. Sophie, I'm going to give you the last word here. Do you want to talk about public health, and is there something that public health can do? There was a comment in the chat box that 4,000 deaths are anticipated in Nepal in the very near future. What can we do globally to slow the death rate?
So I'm sorry, Dr. Buddha had to leave, but I wonder if we could get Stefan Peterson to comment on that final comment, Dr. Fisher.
Sorry, I missed that Sophie left. Please, Stefan.
I thank you, colleagues. I think we need to go back to what Sulfi said in the beginning. It is, and what my consultant told me when I was a medical student, the most common conditions are the most common conditions. And certainly we need to keep up our treatments of the regular febrile conditions. We need continuity of services. We need to keep immunizations going. And I think we should actually weigh in as much as we can to make sure that the resources coming into countries now actually get invested in things like water in health facilities and oxygen systems. And that's what we can do to save most lives. So I think it was been a fascinating hour here, hour and a half to listen to this, but we, as Karen pointed out, this is an extremely rare condition that we spend most time on, which reminds me of medical school. It was always inversely proportional time allocation to how common conditions are. So let's treat our pneumonias, let's immunize, and let's make sure that we keep going on that front. And that's how we will save most lives. Thank you. And by the way, the indirect effects. Let's liberate kids to go back to school.
I couldn't agree with you more. We need to get children back in school, and we need to get children immunized. We saw after the Ebola outbreak in Western Africa that there were huge outbreaks of measles because people were not being immunized. Please, let's not see this repeated globally. I think we have a lot to be worried about. And I love getting children back to school. That really is their job in life, and we really need to let them get back to it. So with that, I'll turn this over to Naveen to kind of end us up from the IPA, please.
Thank you so much, and thanks to all panelists and speaker, moderators, a wonderful job. And this will be posted on our, within 1 hour, it will be available on YouTube channel. So you can continue to share the link with other, and I request everyone to subscribe to YouTube channel of IPA so you get notified when we have next webinar. Thank you, and we just stop the webinar here. Amrita.
Okay.
Thank you.
Bye.